Hello, good morning, everybody. My name is Ben Liu. I'm one of the cardiology fellows at Cornell here with Fits on the Go. I'm here with Dr. Daeman, who presented one of his big trials recently here at ACC. And we're just here to have a conversation about the trial itself, a few questions about some details, and just learn more about it. Okay, so Dr. Daeman, can you tell us a little bit about the trial and sort of the impetus behind it?
Yeah, so we ran the Fast-3 trial, which was a multi-center randomized controlled trial across 37 sites in Europe, 7 countries, in which we randomized 2,235 patients to angio-based physiology using VFFR, the index of CAS software by Pi Medical, versus FFR as being the comparator arm, so conventional pressure wire adenosine-based FFR, with the aim to test whether a angio-guided approach using VFFR was non-inferior to FFR, with the primary endpoint of all-cause death, NEMI, or any revascularization at 1 year.
Mm-hmm. And how did the trials? How did the results show?
Yeah, so what we found is that the angio-guided approach worked very well. So the operators were able to use the VFFR platform within 97% of the cases, as opposed to 99% in the FFR arm. And the investigators also actually trusted the values that were obtained, which was reflected by the fact that 96% of the cases were actually revascularized in line with the physiological result either obtained by VFFR or FFR.
I see.
That resulted in a slightly lower VFFR value as compared to FFR, reflected by the fact that somewhat more patients in the VFFR guided arm were actually revascularized, about 8 to 9% more. However, if we looked at the primary endpoint again of all-cause death, NEMI, or any repeat revascularization, the incidence was exactly identical, with 7.5% events in both arms, with a P of non-inferiority of 0.004, with which we met the predefined non-inferiority margin.
And why do you think that there was an increase in the VFFR range?
Yeah, so that's quite an interesting question. So what we found in the Fast-3 trial something that actually was not seen before in the clinical validation trial. So what we found is that when we validated the algorithm and the platform, is that the diagnostic accuracy was actually very high. So we found the diagnostic accuracy of 0.8 to 0.9, sensitivity, specificity figures of about 90%. And that was very consistent across analysis across each of the individual arteries. So LAD, RCA, LCX, actually no clear differences. But Phase-3 Europe already demonstrated that if you use angio-based physiology in the right and in the circumflex, the likelihood that you find lesions that are actually physiologically positive is higher. And that's a similar thing that we found in Fast-3, and also finding that was replicated within the All-Rise trial that was simultaneously presented and published. Why that is exactly the case is yet to be determined. What we found, if you go a little bit more into the details, is mainly due to lesions in somewhat smaller vessels that may be penalized by diffuse disease, smaller calibers, etc. But why that actually is the case is yet not completely clear. It may have also something to do with the hydrostatic effect with the conventional pressure wire-based system that is obviously not present within an angio-based platform, but that is yet to be determined.
I see. And so the results from your trial, how do you want clinicians to think about it, and how do you feel like you can be interpreted and implemented in their own practice?
Yeah, so that's a great question. And I think the good thing here is that we now have 2 platforms, both FFR Angio, so the CathWorks platform, as well as the Pi Medical platform with VFFR, that demonstrated now in over 4,000 patients that angio-based physiology in well-selected patients is a very good alternative to conventional pressure wire-based platforms. And with that advantage that if you do an angio-based physiology, there's no need for guiding catheters, no need for invasive coronary artery instrumentation, no need for hyperemic agents. And the good thing is with that, you reduce procedure times with about 5 to 6 minutes per case, which is a good thing. You reduce contrast, you reduce radiation dose, which actually makes the technology more accessible and also more applicable to even to labs who do angio only. So I think this could be a game changer in the way we use physiology in the upcoming era.
Nice. So I think, the technology for the angio and the Vessel-Ffr have been around for 20, 30 years. Why did it take so long for it to come now?
Well, the concepts, indeed, you're right. The concept of angiography-based physiology are not new. So they date from the late 90s. But that said, I think it took some time to go from the extensive computational fluid models,
Mm.
which took hours to computate the physiology on a vessel basis, into these more simplified algorithms that now actually are able to computate the physiological result within a matter of seconds.
Mm.
I think that took time, and then obviously multiple vendors are currently on the market assessing their platforms. They need clinical validation, so preclinical validation in phantom models, clinical validation in retro and prospective studies, and then it takes time to do a large-scale outcome trial. For Fast-3, it took 5 years to get the results.
Right.
All-Rise, a similar 4 to 5 years of efforts that were spent to get to this result. And I think that is apparently what is needed to validate these new technologies. But I think with these efforts, specifically in the past decade, we now have at least 2 technologies that are ready for prime time.
Wow, that's amazing. In your own clinical practice, do you see yourself using a lot of these technologies, or have you already started using them?
Absolutely. I think that's definitely it will be a game changer after the results of these trials. There was a lot of reluctance to use these indices, specifically after the FFR3 Europe trial, which actually demonstrated that the use of QFR in this case did not meet its non-inferiority endpoint versus FFR. But now with both VFFR as QFR, as FFR angio, we have 2 systems that are ready to go in patients specifically. And I think that's an important thing to note. Most patients within both trials had stable angina, 80% in Fast-3, 90% in the CATWorks trial. So I think that illustrates a little bit in how physiology is being used, at least within the patients in these trials. So if patients present with stable angina, have good quality angiograms, no aorto-osteal or left main disease, I think then these technologies are a very good and appealing alternative.
Oh, that's great. Do you feel like with the uptake of these different procedures, what do you think is the ideal patient for someone to use for this and specifically?
Yeah, so as mentioned, I think what is critical specifically now based on the results of these trials, start with stable patients, good quality angiograms, no significant foreshortening or overlap, and particularly no aorto-osteal disease.
I see. Okay, that makes a lot of sense. And, with saving time, procedure time, saving, medications and adenosine, all these sorts of things, and decreasing risk for the patients themselves, is there additional health economics that you're going to evaluate further as well?
That's a great question. So yeah, obviously, if you anticipate the fact that the FFR angio platforms decreased procedure time, decreased contrast volume, reduced resources needed, no guiding catheters, no wires. It's basically no-brainer that this technology is more cost effective. However, and that's quite interesting, what we found is that it also results in somewhat more revascularization, somewhat more stents. So I think we need to figure out how the final cost economical models will look like. But that's definitely something that we're working on, and we will be able to report in the near future.
Okay, great. Is there going to be a Fast-4 or anything else afterwards?
Yeah, that's obviously the $1 million question. We have several ideas which are currently being explored, but more to come on that.
Okay, no, that's great. All right. So, those are all my questions, but is there anything else that you wanted to say, Dr. Daeman, before we...
No further comments. It was a pleasure being here, and thank you for watching.
No. Thank you, everybody. This was ACC Fits on the Go. I'm Dr. Liu. This is Dr. Daeman. Thank you, and follow us on Twitter at x.accfitsonthego.